Hello, my name is Dr. Neil Iyengar, medical oncologist. I'm the co-director of breast medical oncology and director of cancer survivorship at the Winship Cancer Institute of Emory University. And I'm joined by my good friend and also colleague, Dr. Komal Jhaveri. Could you please introduce yourself?
Of course, Neil. Thank you so much. I'm Komal Jhaveri, breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York. I actually have dual appointments within the breast and the early drug development services there. I'm the section head for our endocrine therapy research program, and it's really a pleasure
Wonderful.
to be with you, Neil.
Likewise, a big pleasure, and we're very excited to introduce the Cancer Unfiltered podcast by Komal and Neil. Maybe we'll start with the hormone receptor positive space, and certainly we've seen a lot of data, right, for oral SERD therapy. You've been really at the forefront of leading a lot of those trials. And we have 2 oral SERDs that are approved in the metastatic setting. Elacestrant, based on data from the Emerald trial, is our first approval for an oral SERD. And imlunestrant, based on the recent EMBER-3 data, which you presented as well. Now, both of these are approved as monotherapy. And I know that we've had lots of conversations amongst ourselves and amongst our colleagues about monotherapy versus combination therapy. And I think, seeing these approvals specifically for ESR1 mutated hormone receptor positive metastatic breast cancer is a step in the right direction in terms of treating what we considered to be endocrine resistant disease with the ESR1 mutation. Now we can overcome that with an oral SERD. But I think the question is, what do we do when we have other molecular therapy partners which are approved with, for example, fulvestrant, but we've run out of the endocrine therapy backbone by only so many times you can use fulvestrant. And so before we get to that, I just want to mention that I was excited to have another SERD like imlunestrant available, even as monotherapy, because I think these drugs are very well tolerated and provide another option. But what are your thoughts on the monotherapy and combination therapy debate?
Yeah, no, very exciting time. Really come a long way in understanding at least some of the mechanisms of resistance to anti-estrogen therapies, ESR1 mutation being the most prevalent one here, with about 40 to 50% that can the tumors can have these mutations by the second or third line metastatic setting for hormone receptor positive disease. And always good to have more options, right? We're spoiled in that we have 3 CDK4/6 inhibitors. We have more than 3 now, or at least 3, antibody drug conjugates. We have 3 aromatase inhibitors, and we've been used to having these options because we can choose one, and sometimes we choose one for a particular reason, and sometimes it's the toleration that the patients talk to us about and makes us want to switch. And so it's nice to have these options. So it's great that we have imlunestrant approved as of September 2025. But as you pointed out, I think while we appreciate how monotherapy is so impactful in that if you have somebody who's had endocrine sensitive disease, who's been on a CDK4/6 inhibitor for a very long period of time, we've seen that these monotherapy drugs could actually work more durably than what the data suggests in those particular settings, I think.
Yeah.
But we've also recognized that's not majority of the patients. In fact, 40% of these patients do not respond to endocrine therapy very, very well. And about 60% land up having, tumor progression in a short period of time, kind of underscoring the importance of combination-based therapies. And so I think it's really, really an exciting time to have all these combination data available. We have EMBER-3, which gave us some data on imlunestrant with abemaciclib. It's nice to see that now we have NCCN guidelines that were recently updated in January. Now talk about that and endorse that as well. So hopefully we can get some access to that. We know that the FDA is now going to evaluate the doublet data. We'll see what comes out of that evaluation. And then more recently, not only did we see this EMBER-3 doublet data where we saw the benefit regardless of ESR1 mutation. So in ESR1 mutants, we saw 11 months. When you don't have ESR1 mutations, we still see that a comprehensive blockade with 2 drugs worked better than the monotherapy component, which only is approved and works in ESR1 mutant tumors. So I think gives us some hope that maybe we can do better than what we're able to do with single agent drugs. And they're tolerable, which is nice, right? I think it's not the SERDs, as you said, that necessarily add on to the toxicity profile. And we're talking about as a class. I think whether it's giredestrant, whether it's imlunestrant, whether it's elacestrant, whether it's camizestrant, I think we've heard about vepdegestrant, the PROTAC as well. Overall, very nice to have data from all of these drugs where we see a signal for ESR1 mutant tumors as monotherapy, where we see very well tolerated, toxicity profiles for our patients, and now these combinations that it's making more exciting. So beyond imlunestrant doublet, I think we also heard the data from the Iyengar trial.
Yep.
And so giredestrant with everolimus, again, completely different targeted partner with an oral SERD. But again, we saw a signal in ESR1 mutant tumors about 10 months. So in line with the combination that we saw with imlunestrant abemaciclib was 11 months. And we saw activity in intent to treat. Although I have to say, the filing with the FDA, and we're going to hear more about what happens with the FDA review by December of this year, is going to be in the ESR1 mutant tumors for giredestrant and everolimus. So we'll see that. And then beyond that, I think with combinations, we've also had very good strategies, such as the SERENA-6 strategy, right?
Yes.
Something which was an extension from the PARA-1, where we were trying to not only look at newer drugs and novel endocrine agents and good combinations, but we're also banking on newer technologies like ctDNA to identify these ESR1 mutations, even before the historical traditional ways of looking at progression with anatomic progression using scans.
Right, truly precision medicine, right?
Truly precision medicine. So we're trying to capture them as they're happening in the tumor biology and trying to see if we were to intervene ahead of the anatomic progression, can we actually improve outcomes? And at least we were able to improve the progression-free survival with SERENA-6 by switching to camizestrant, continuing the same CDK4/6 inhibitor versus continuing the AI-CDK where the patient started. We're awaiting the OS data. We don't have that available from that. But I think one thing to mention there was the nice quality of life data.
Yes.
That actually was impactful for a patient in clinic. So I think we'll have to wait and see how these combination data and these strategies unfold. But I think my theme or my take from this is going to be that oral SERDs work. They could be useful as monotherapy in ESR1 mutant tumors. Combinations are going to be more efficacious. They seem to be very safe. The toxicity profile predominantly driven from the combination partner targeted drug, whether it's a CDK4/6 inhibitor, whether it's an agent targeting the PI3K/AKT/mTOR pathway, in this case everolimus first. I think SERDs are well tolerated. We have to yet determine what's the best strategy that we will adapt in clinic. But again, maybe we might have more than one strategy. We will have updated data from the first-line trials, such as Persevera, where we're trying to see for endocrine-sensitive tumors, could we use these combination CDK and oral SERDs up front in the first-line setting and delay emergence of ESR1? Could that be a strategy we should use for all? Could we use a SERENA-6-like strategy where we will have to figure out how to serially monitor them? When should we start serially monitoring? Trials started after 6 months, but the time that, it took, median time was about 22 months. So could we wait and start later? Do we do it for all patients? Should we wait for the second line strategy upon radiological progression and use Iyengar or EMBER-3-like data? Again, we have choices.
Yes.
We will discuss them with our patients. It's good to have options. I'm very excited about the field.
Yeah, I couldn't agree more. I mean, I think that, you brought up a lot of great points. And, I'm particularly excited about the point you made with regard to imlunestrant abemaciclib combination working regardless of ESR1 mutational status. We also saw some data specifically in the cohort of patients who were previously exposed to a CDK4/6 inhibitor and those who also had PIK3CA alterations as well. So one of the debates that I think we're still having is we talk about precision medicine. We've talked about SERENA-6 and molecular resistance emerging. But are we actually moving away from precision medicine if we start to identify combinations that work, that are agnostic to the molecular alterations? And I think that's a tricky question. My own view is that I don't think we're necessarily moving away from precision medicine. I think that we're identifying strategies that work across the board. And you really pointed out a couple of trials that have given us more information about clonal evolution. And I think SERENA-6 highlights the need to understand when to target the emergent ESR1 mutation. Do you target it right away? Or do you target it second line or beyond, as you mentioned? And so I think that longer term follow-up, the OS data you mentioned that we're waiting for, is going to be very important. But the issue is, what do we do right now for our patient sitting in front of us? And I think for me, it really comes down to having this frank discussion with our patients and saying that this is the state of the data. And this is what we have. Let's assume that all of this gets approved. And we're sitting there with the patient and saying, well, we have all of these options. I think ultimately it would come down to certainly efficacy, but it would also come down to being transparent about the fact that we're still trying to figure out how to use this relatively new approach of identifying emergent molecular resistance and when to target that resistance. And then finally, as you mentioned, patient factors, side effects, toxicity, and so forth, to come to shared decision-making with our patients. I think all of that data that you highlighted, and I like to call this our data dump, if you will, is in our unfiltered way, is really something that we have to do delicately with our patients, but also share that data, right, with our patients so that we can make that shared decision with them and yet also guide them in terms of how we interpret that data. And certainly lots of controversies still exist with regard to sequencing and how we use these drugs and when we use these drugs. But I think ultimately having these options are really critical. Now, the early stage space is also changing quite a bit, and that might also influence, and we'll talk about that, but that may also influence what we do in the metastatic setting as well. And then additional ongoing combination trials as well in the metastatic setting, where this debate that we're having now about monotherapy versus dual therapy is going to become a moot point, perhaps. I mean, I think ultimately it'll be interesting to see the efficacy of dual therapies versus monotherapies and take into consideration the potential added toxicity, especially if you're using agents that are known to have toxicity, right?
Absolutely.
Targeting the AKT PI3 kinase pathway, for example. So a lot to consider here.
Absolutely agree. I think I'll piggyback on what you were saying and made me think about this a little bit more. I think, it's really funny how we have come in a way in a more complicated circle the way we began, right? We thought it was so easy. We have an estrogen receptor positive tumor. We can go after the estrogen receptor as a target and boom, we will be able to, treat those cancers effectively. And what we learned was those strategies work, and we really need to target the estrogen receptor, but then endocrine resistance happened. And then we started to spend so much time trying to understand these mechanisms of resistance and then go after those resistance mechanisms as a target, ESR1 being a very good example, right? That's a mechanism of resistance that can be targeted again with a novel anti-estrogen agent. But as we're doing this, I think we're also realizing that this has gotten so complex.
Yes.
Right? We went from a simple world of having 3 anti-estrogen drugs and ways of treating ER-positive breast cancer to now having so many different combinations and so many different options. And the complexity here is, how do we think about using these options?
Right.
How do we sequence them? How do we use them all? Do we need to test for the mutation? Do we now care if some combinations work regardless of the mutations?
Right.
But I agree with your sentiment. I think it is helpful to understand these. Not one strategy is going to work for all. I think we will have to appreciate that we will at the very least understand what's happening inside the tumor as a biology, as a prognostic way of understanding what might come our way. And then patient preference, in addition to all the factors, is really going to be key here as well. Like, I could see one patient sitting in clinic in front of me saying, wow, you can actually tell me what's happening to my tumor when I'm getting this therapy and then go after that even before I can have bone pain. And I want to do that.
Yes.
Versus somebody who'll be like, oh, so do I have to do this testing all the time? I have this option at the back end. Can I do this at the back end? I can see so many of this variation. So once these options are all available, I think it'll be our discussion with the patients, making them understand what we have learned from the data, what is still pending, what do we don't know about them,
Right.
what kind of options they might have at the back end or now, and then having a discussion about the toxicity profile, what it will take in terms of their contribution in a clinic, and then figuring out a right strategy. So great, exciting data, lots to learn,
Yes.
lots to do,
Right.
But looking forward to more of this.
Yeah. By the way, do you remember, when we were fellows and, people would say to us, why would you go into breast cancer? It's so boring. Look at us now.
I know,
I think
right?
this is the best space to be in.
I completely agree. I feel like the survival differences that have, been appreciated in the last few decades make me feel like that was the best choice I've ever made, because I think the most I enjoy with breast cancer care is the longitudinal journey that I
Yes.
can be with the patient. may it be early detection, may it be diagnosis, may it be treatment, may it be recurrence, may it be treatment with all these great options that we now have available, with the idea of trying to improve survival, be with them, and then think about survivorship, something that's near and dear to you.
Absolutely.
I love your optimization of lifestyles and how exercise and things beyond can actually make a difference. So a long journey that we want to spend our time with our patients, for our patients, along their side, which is why we're in breast cancer together and enjoy doing that.
Absolutely, absolutely. And I'm so thrilled that you brought up lifestyle because, as you know, that's near and dear to my heart. But it's so cool that we're now talking about that in the metastatic setting.
Absolutely.
Right? It really shows us where we've come in terms of treatment options, that people are living longer, much longer now in the metastatic setting, where we really have to consider quality of life, as you've brought up, and we can now consider lifestyle and survivorship interventions even in the metastatic setting.
They certainly go hand in hand, and I'm sure we'll talk more about that when we talk about toxicities and what kind of toxicities where this would be even more relevant.
Absolutely, absolutely. So, all right, let's move to a hot take, and a hot take on antibody drug conjugates. You brought this up briefly before we got into the SERDs. So shifting to antibody drug conjugates, we've also seen a lot of data there, and this has been a really exciting space, right? And so in the triple negative space, I think this has been an exciting area because, of course, this is historically such a hard disease to treat, right? Well, all we had was chemotherapy. Certainly back when we were training, this is all we had was toxic chemotherapy. We still use a lot of chemotherapy, and it can be effective in certain situations. But I think we're moving away from that in the first-line setting. And we've seen some recent trials, ASCENT-03 and 04, which were the phase 3 trials that tested sacituzumab with or without immunotherapy, pembrolizumab, in the first-line setting. And we saw progression-free survival benefits in both trials. Now, I think what's tricky is we talk a lot about how our treatment options have improved dramatically. And in some ways, that works a little bit against us because in both ASCENT-03 and 04, crossover was allowed, and that was the right thing to do, of course. So patients that were randomized to the physician's choice chemotherapy arm, right, they were provided with sacituzumab govitecan as their subsequent therapy. And this, of course, makes it challenging to interpret the overall survival endpoint. And I think that, it was the right thing to do in the trial, but the question now is, in a landscape where we're seeing other ADCs, how do we make those treatment selections choices, right? So, for example, we saw the TROPION-Breast02 trial, and this is another TROP2-directed ADC, datopotamab deruxtecan, versus physician's choice chemotherapy. Now, there are key differences in the trial designs between TROPION-Breast02 and ASCENT-03 and 04. One of them being TROPION-Breast02 was in patients who were ineligible for immune checkpoint inhibition. So in the current state, we need to use sacituzumab govitecan if we're planning to use pembrolizumab, right, in the first-line setting. But I think if we look at patients or if we anticipate the near future where we might need to make the decision between something like datopotamab deruxtecan and sacituzumab govitecan for first-line treatment of triple-negative breast cancer, there are some subtle differences in the trial design. For example, in TROPION-Breast02, those rapid progressors from the adjuvant setting were allowed, those who progressed within 0 to 6 months. And I think that's really helpful because those are patients we really do struggle with treating, right? The other pieces in TROPION-Breast02, overall survival and progression-free survival were co-primary endpoints. And in my mind, that is really nice to see because it reserves alpha or power for the OS endpoint as well. OS is typically a key secondary endpoint. And we saw both a progression-free survival and an overall survival benefit with datopotamab deruxtecan in TNBC. And I think it's incredibly exciting to have a treatment option that has an OS benefit in such a difficult to treat disease that allowed for early progressors, right?
Yeah.
So this is, I think, really exciting times also for triple-negative breast cancer. But we can't forget about the activities of these drugs in the hormone receptor positive space, right?
Absolutely. Yeah, no, I think, your point about crossover, I think is very, very important. And I think we really have to recognize this, that we obviously want to ask this question, was there crossover allowed? Because that's the right thing to do, as you said. And I agree with that. I think that's the right thing to do. And, it was really applauded by everybody that, yes, we were able to do that in ASCENT. And maybe in a way, a little bit of a reluctance or a disappointment that we did not do that in TROPION-Breast02. But I think we have to take a step back and think about this, right? I think Ascent already had sacituzumab approved in triple-negative breast cancer. So I think you have that drug already approved in the second-line beyond setting in triple-negative breast cancer. So it was the right thing to do to allow crossover, because that's what normally would have happened in standard of care practice. And we can't necessarily easily do that with newer drugs coming in that space that don't necessarily have approval in that space. And so while one says, oh, Ascent had this and TROPION-Breast02 did not have that, we have to recognize datopotamab was not approved in the triple-negative breast cancer space. And for us to appreciate the full potential of this TROP2 ADC in this difficult-to-treat patient population, especially given the differences in patient population, including that 15% of the patients who had progression within 6 months, I'm glad that we are able to show this overall survival benefit. So as much as I want crossover and overall survival to be determined based on that, it's not very straightforward to do that with drugs that are not already available or approved. You cannot necessarily force upon something that is not already approved in that setting and tell a physician, do this as a crossover. So I can see how we should appreciate all of that when we're evaluating these data. I think one thing common between the two trials that we still struggle with a little bit is that only 5% of the patients had prior pembrolizumab. And now in the days of Keynote 522, where majority of our triple-negative breast cancer patients are being treated with that, while we had fast progressors, we still have to figure out, is this the same activity we should expect in the pembrolizumab tumors that have had progressors? So I think that's common between the two, that hopefully maybe some real-world data eventually will be able to help. But I think regardless to say, great options for us. ADCs work.
Yes.
I think very important to recognize the attrition rate in triple-negative breast cancer is farthest, the largest we can see in any subtype, right? 50% might not make it to the second line setting. And that's a big deal. And so having these impactful data, having these data sets like TROPION-Breast02 with 65% response rates, right, in the first line setting, or, getting great progression-free survival benefits in both studies, getting an overall survival delta of 5 months in the TROPION-Breast02 is very encouraging, very reassuring. And I think very important to look at.
Well, how many times have you had, a patient with metastatic triple-negative breast cancer who comes in with a pleural effusion or pain, right? And to see a 65% response rate is really remarkable. And to be able to reduce tumor burden in those patients that are symptomatic from their tumor burden with datopotamab deruxtecan, I think that's really exciting.
I feel very gratified and very happy when, I'm able to quote that. I'm able to say, yes, we can do this. This will respond and we can give you something that will work, because it's so disappointing not to be able to do that. And we went through years of that with triple-negative metastatic disease. So I think it's very nice to see these antibody-drug conjugates having an impact in clinic for patients, even with the toughest and the most resistant kind of tumors. And I'm really hoping that we have more of these for triple-negative breast cancer and more kinds of treatments that we can offer our patients and continue to further improve outcomes for our patients with that disease. Having said that, these drugs are impactful even in HR-positive breast cancer. So sacituzumab was already the first one as a TROP2 ADC that was approved even in hormone receptor-positive disease. That was TROPiCS-02. That gave us both a statistically significant progression-free survival benefit, which was modest, but this was a very heavily pretreated patient population. Median of 3 prior lines of therapies, almost everybody having a prior CDK4/6 inhibitor compared to chemotherapy, but then also an overall survival benefit. So we certainly have that data available with that drug. So naturally, our next question was, should we bring this early on in our treatment paradigm? Can we bring that in the first-line setting, and will that further improve outcomes for our patients? Now, sadly, when we did that question and addressed that in the ASCENT-07 study that we saw the data for this past San Antonio, we learned that it did not necessarily make a difference when we compared it with capecitabine or a taxane and evaluated the primary endpoint in that study, which was blinded independent central review. So median progression-free survival by blinded independent central review. Now, again, I think it's very interesting to see the slight discordances that we would see with local assessment of progression-free survival and blinded independent assessment.
Isn't that interesting?
It always is. And I think it's becoming more and more in HR positive. We're recognizing this more and more because we have treatments that patients can get at the back end that have survival benefits, because investigators have the whole picture in front of them, right? They know what the patient is feeling. How are they tolerating it? Do they have clinical symptoms? Do they have tumor markers that sometimes we monitor, in addition to radiological assessment, which is all what a blinded central review would do. And so surely in the Ascento 7, interestingly, the local assessment had a numerical improvement in the sacituzumab arm compared to the physician choice chemotherapy arm. But at the end of the day, the primary endpoint was blinded independent central review. The trial did not meet its primary endpoint. There is an interesting signal in IHC0 tumors because for our HER2 low and ultra low, we have trastuzumab deruxtecan, very, very impactful drug again that we use across breast cancer subtypes, right? Majority of our patients can get this drug now with great benefit. But for the IHC0 tumors, it does seem like there could be potentially a signal. So we'll see, we have an ongoing Tropion Breast 06 trial trying to focus in the first line IHC0 tumors, looking at datopotamab. So we'll see what that shows if we learn something from that. We'll have other data sets that are going to come out as well, including the Trofuse 10, which is the third Trop-2 ADC, third kid on the block, sacituzumab tirumotecan, or SAC-TMT as we call it. And that's an ongoing study in HR-positive first line with or without pembrolizumab. So we'll see how that does and whether high Trop-2 expressors might have a better benefit. We'll learn from that study as well. So looking forward to newer data sets in that space. Today, we have sacituzumab as an option in a heavily pretreated patient or a patient, as NCCN has guided us with and other guidelines have guided us with, where TDXD might not be something that you can use, or a TDXD ineligible patient where you could use it sooner, or in a heavily pretreated patient that we can use it. But we also have Tropion Breast 01, which gave us approval for datopotamab. So we have that data for HR positive, and we have that drug available for HR positive patients. And again, we saw a great PFS benefit. We did not see a statistically significant OS benefit. Again, goes in line with what patients are able to achieve. So when Tropion Breast 01 was designed, we had approval for TROPiCS-02. We had approval for TDXD. So we have access to those kind of drugs at the back end. And when we did a sensitivity analysis in the Tropion Breast 01 trial, acknowledging that ADC use, we did see that the benefit was better and the hazard ratio was a little better than not. But it did not meet statistical significance, yet it's approved and available. And now we have to figure out how to choose and what to choose from these available agents. And I think we bank on the toxicity profiles that we look at. So sacituzumab, we think about neutropenia and diarrhea. And when we think about datopotamab, we definitely don't deal with a whole lot of neutropenia at all. We don't definitely deal with diarrhea at all. We deal with the nausea that we deal with TDXD, but we have, thankfully, the triple anti-emetic regimen and olanzapine as needed. And I think very, very important for us to remember that. That's the most common side effect with these deruxtecan payload ADCs that we have available for patients. And then we think about stomatitis. So a plug for not to forget to start primary prophylaxis with dexamethasone mouthwash.
So important.
And we some very low-grade dry eyes or ocular side effects. Again, something that we don't necessarily always ask our patients. I don't know, when was the last time you asked a patient receiving a taxane or gemcitabine in clinic, do you have dry eyes? Right? I don't remember doing that. But I think when we did that with datopotamab, we obviously learned a lot more. And that's what we've learned. So yes, we want to be vigilant. Yes, we could have one ophthalmological assessment at some point. We can use artificial tears, avoid lenses. But I think my experience, at least with that, has been that it's predominantly low grade. And then there are differences in their administration schedules, right? Sacituzumab is day 1, day 8 of a 3-week cycle. It's a longer infusion time as well for patients. And then datopotamab is every 3 weeks. And it's a shorter infusion time. So I think all of these factors, patient preferences, again, will come into play. Great to have options. We need to educate them about the side effects, the administration profiles, and then figure out what's the best way to use them. We have options, we want to use them.
Right, absolutely. And I think also the proportion of patients with some degree of HER2 expression really is the majority of patients.
Exactly.
And really makes trastuzumab deruxtecan an option for a lot of our patients. I mean, I'm certainly using a lot of TDXD and looking for that ultra low expression of HER2 in the hormone receptor positive space, or even low expression in either the hormone receptor positive or negative space to use TDXD. But I think having Trop-2 directed ADCs is really critical in the hormone receptor positive space as well, because this is a different target, right? And so we can sequence potentially, and we'll talk about sequencing, but we can talk about changing the antibody target as a potential sequencing method because this, of course, is another controversial area. But I very much resonate with your point about toxicity. I think that, for me, what's striking is that we're used to sacituzumab govitecan. We've been using it for a long time. We know how to manage those toxicities. I think that when you look on paper at the AE reporting for datopotamab deruxtecan, it raises some alarm in some folks that are not used to dealing with a dry eye and things like that, or mucositis prophylaxis, although we do that for other drugs in breast cancer. But my experience in clinic is that almost it's better than what's on paper, that the tolerability of datopotamab deruxtecan is actually really quite good. And I think that, yes, we have to be proactive. So for me, the differentiator is how proactive is the patient. If they're a very motivated, proactive patient who's not going to drop the ball on that dexamethasone mouth rinse, who's going to do the eye drops and see the ophthalmologist or the optometrist, that's the patient that I would feel really excited about using something like Dato-DXd, because I think it's very well tolerated overall if you're proactive. Sacituzumab govitecan, on the other hand, I think we know how to manage those toxicities. We've been managing diarrhea. We've been managing neutropenia. If you use the growth factor in the appropriate way after day 8, or if you use short-acting growth factor after day 1, you can manage that as well. So I think all of this comes down to not only our preferences and comfort, but the patient's preferences and comfort, as you pointed out as well.
Yeah, no, absolutely. I think toxicity, proactivity management is very, very important, especially because it's a stomatitis, which I think is very, very important to proactively do. And so I think it is something that we really will have to gauge and discuss with our patients for sure.
Absolutely.
But I think this was great to talk about the hot takes on these data with antibody drug conjugates until we discuss some more.
Yes.
All right. That was really fun chatting with you about all these
Absolutely.
data drops and hot takes that we had about endocrine therapies, mechanisms of resistance, and antibody drug conjugates.
Yes.
Really enjoyed having this discussion with you, Neil, as always.
Likewise.
Love to have additional conversation. Well, for that, stay tuned for the next one. I think in a month we'll have something more to discuss, something more unfiltered to talk about with Komal and Neil, and we'll have more data to discuss at then.
Wonderful. Always a pleasure.
Thank you.